Hello, your doctor has diagnosed you with an abdominal aortic aneurysm. An abdominal aortic aneurysm is a weakening in a blood vessel which causes it to get larger than its normal size. Normally, the heart pumps blood, and the largest blood vessel in the body wraps around the chest, around the heart, and gets into your abdomen. Once it enters the abdomen, it's called an abdominal aorta. The normal size of the aorta is about 2 centimeters. When it grows to 3 centimeters or greater, it is defined as an aneurysm. And certainly when it grows to 4 or 5 centimeters or greater, we have to start watching it carefully and talking about certain therapies and treatments that are available for it. Basically, an aneurysm forms from a weakening in a blood vessel wall. It could be from atherosclerosis, it can be from inflammation, etc. What happens is that the wall weakens and it dilates, and it weakens and it dilates, and it loses its integrity. And the biggest risk of an aneurysm is that it can go on to rupture. And if an aneurysm were to rupture, it could lead to catastrophic internal bleeding and possibly death. In general, there are 3 options for treating aneurysms. When the aneurysms are small, less than 5 centimeters, and when they have not had a lot of rapid growth, we can certainly manage them medically. And what that means is we can follow them by serial ultrasounds and routine evaluations at every 6 months or every year thereafter. If aneurysms reach a certain size that tell us that the aneurysm is growing fast, or if the aneurysm has reached 5 centimeters or greater, then we have to talk about treatment. And currently there are really 2 options for treating aneurysms. One is the standard surgical option, which is called the open aneurysm repair, where you undergo a surgery, we have to make an incision, get inside, and fix the aneurysm directly. The other is the endovascular approach, which is the minimally invasive therapy, which has now been practiced for almost 20 years, and we have lots of data on this. But that is somewhat of a less invasive therapy in that we can treat the aneurysms from remote incisions in the groins, where we travel the catheters from inside the arteries to the aneurysm and exclude the aneurysm from within. I'll give you an example. Imagine a water hose that's been sitting in your garden and is pressurized, and it gets a ballooning within the water hose. Now that is what an aneurysm would look like. Now that has a risk of rupture and bursting. To prevent that, instead of going directly at the water hose to replace that, what we do is we travel from one end of the water hose, travel from inside that hose, and reline it with another water hose to take the pressure off the dilated part. And what that really does is that reestablishes the flow of water, in this case, or the flow of blood through the hose, and takes the pressure off the weakened part. Does that make sense? If your aneurysm is small, less than 5 centimeters, it's not symptomatic, it's not causing you to have any discomfort, and it hasn't grown rapidly in a recent past, then the standard treatment is to watch the aneurysm over a period of time. What we would do is do periodic ultrasound evaluations and clinical examinations to make sure that there isn't any part of the aneurysm that is growing and or symptomatic. In that case, we would follow you every 6 months, do an ultrasound, and go through some risk factor modification. There are 2 independent risk factors that are associated with aneurysm rupture. One is hypertension, and the other is chronic obstructive pulmonary disease, essentially asthma and emphysema. Now, we can't take asthma and emphysema away from you, but if you have high blood pressure, we can talk about controlling the blood pressure so that the risk of rupture of this aneurysm is controlled and lessened. I'll stop there. You ready? Now that we know you have an aneurysm, let's talk about some of the testing that is needed for us to get a better handle on really what's going on. We need to start with getting a CTA. A CAT scan is an evaluation of an aneurysm that gives us a very detailed picture of what the aneurysm looks like from outside as well as from inside. It allows us to do lots of measurements that are needed to design or to prepare the best stent graft that we need to fit into your aneurysm anatomy. And outcomes clearly are focused, and outcomes are clearly dependent on how good our ability is to match the best stent graft to your anatomy or your aneurysm's anatomy. I'll stop there. A CAT scan is a very simple test. Everyone today has a basic understanding of what a CAT scan is. It's a machine that you lie down and go through. With the 64 slice CT scans that are available today, the test can be done within 15 to 30 seconds. There's intravenous dye that is given by IV that's placed in your arm. The procedure is very simple. You simply have to lie still for about 15 seconds to 30 seconds. And the CAT scan gives us a very detailed information of what is going on with your aneurysm, its size, its shape, and other associated findings with the aneurysm. In certain instances, besides just a CAT scan, we might have to do an angiogram. An angiogram is a more invasive procedure which involves local anesthetic and conscious sedation. We give you numbing medicine over your groin area, puncture the artery, and put a catheter inside the artery that travels to the level of the aneurysm. We take pictures using contrast agents, and it gives us a very detailed evaluation of what the inside of your aneurysm and your anatomy looks like. And that sometimes helps us delineate how to better design or how to better match the stent grafts to your anatomy. It certainly helps us identify some other associated problems, such as blockages in the arteries that go to your kidneys, or the arteries that go to your bowels, or the arteries that come down to the groin level, which are called the iliac arteries, which all need to be a certain size for us to be able to do this procedure safely. I'll stop there. Let's talk about open surgical options for your aneurysm. For over 50 years, open surgery has been a pretty standard operation for taking care of abdominal aortic aneurysms. The procedure involves a surgical approach where you have to undergo general anesthesia. Under general anesthesia, the surgeon makes incision in your body in a particular place, either on the flank or in the midline, and we isolate the abdominal aortic aneurysm directly. Once that aneurysm is isolated, we open the aneurysm, put a new prosthetic graft within or around that, and close the aneurysm over the graft. And what this really does is diverts all the blood flow from the good artery above the aneurysm to the good arteries below the aneurysm. And at the same time, it obliterates the entire aneurysm. The procedure is fairly straightforward, although it is a little bit more complex and a little bit more high risk than the endovascular procedure. Endovascular procedure being the minimally invasive procedure, of course. One of the things that happens with the surgical procedure is that the procedure time is about 2 to 4 hours. You will end up spending maybe a day or so in the intensive care unit. You'll spend about 4 to 5 days or sometimes upwards to a week in the hospital. And it takes about 4 to 6 weeks to fully recover, get back towards normal. And then sometimes it takes a little bit longer than that, several months, to really get back towards your normal self. I'll stop there. Let's compare some of the risks and benefits of minimally invasive endovascular therapy and surgical repair. Open surgical repair carries about a 2 to 3% chance of death. That is the biggest risk of all. Outside of that, the complications of heart, lungs, kidneys, bowels, bleeding, clotting, etc., all those other complications that we can get around with open surgery are in upwards of 15 to 18% if you put them all together. With endovascular therapy, the upfront cost of the largest risk factor, which is death, is a little under 1%. So it is less than open surgical repair. Looking at all the other complications, heart, lungs, kidneys, bowels, bleeding and clotting, etc., all those complications with endovascular repair are in the 5 to 10% range, not quite the 15 to 20% range. One of the things that happens after both procedures, be it endovascular or open surgical, is that you will require lifelong follow-up. During the lifelong follow-up, secondary procedures, which are minimally invasive in most cases, are required much more with the endovascular option. In about 15% of the patients over the course of their life, patients will require additional secondary minimally invasive procedures to keep the aneurysm fixed if we go down the route of endovascular repair. If we were to have open surgical repair, that secondary interventions is probably around 5% or so. Now, sometimes you can have other aneurysms that form above or below the site that we have originally fixed, whether we do it by endovascular means or open surgical means. And that's something that really requires lifelong follow-up. I'll stop there. Let's talk about endovascular aneurysm repair. What happens with endovascular repair is that you come to the hospital, you go to the operating room, the procedure can be done under local anesthetic, with a spinal anesthetic, or with a general anesthetic. And it all depends what the anesthesiologists and your doctors decide is the best treatment for you. Obviously, your preference also matters in that. With that, 2 small incisions are made in the groin. We cannulate wires and catheters that travel from inside the arteries and travel up to the aneurysm. Once they are up to the level of the aneurysm, we inject dye from within the aneurysms to take some pictures and identify our landing zones. What we really want to do is place a stent graft in good arteries, in healthy arteries, above and below the aneurysm. Now imagine a stent graft that looks like a pair of pants. It's got a waist and it's got 2 sleeves. The waist has to fit in the normal healthy aorta above the aneurysm, and the 2 long sleeves have to come down and fit into the iliac arteries below the aneurysms. When they fit into the normal healthy tissue above and below the aneurysm, they form a seal so that the blood does not go through the crevices and actually travels from within the limbs of the stent graft. And what that does is that really depressurizes the aneurysm, and that alleviates the risks of aneurysm rupture. The procedure usually takes about 1 to 2 hours. You normally end up staying in the hospital for about 1 day, sometimes a little bit longer, depending on what the postoperative issues are that you might deal with. Even if it is completely uneventful, sometimes it takes 1 or 2 days for patients to really feel comfortable going home. Once you are home, the recovery takes place within the first 1 to 2 weeks. Most patients who come back to the office, in 2 weeks, they want to go back to their normal activities. They want to go back to playing golf and really carry out their daily chores. We ask patients to take it easy for up to a month, refrain from lifting heavy weights, and really not putting strain on the incision sites that we have made in the groins. Now, sometimes the endovascular procedures can also be done minimally invasively by percutaneous means. In select cases, instead of making incisions on the groin, we simply advance a catheter percutaneously through the groin and do the rest of the procedure that way. Percutaneous procedures carry their own inherent risks of arterial injury at the groin level, so we have to balance that in making our decision whether endovascular repair is best by percutaneous or by surgical repair. I think I'll stop there for good. Let's talk a little bit about how we can do the endovascular aneurysm repair. Endovascular aneurysm repair can be done by 2 ways. One is where we have to make incisions in the groin and travel from inside the arteries. The other is by percutaneous access. What that really means is without making incisions in the groin, we simply take needles and catheters, give you numbing medicine at the level of the groin, and enter the artery without making any incisions. The entire rest of the procedure is done exactly like it is when we do cut downs in the groins. There are some pluses and minuses to endovascular repair by percutaneous means, where we don't make incisions, versus when we have to do femoral artery cut down. And we have to weigh that after we get all your imaging and evaluate all the risk benefits associated with that. And we can certainly talk about that later as we get closer to your aneurysm repair.
Good.
Was that better?
Yeah.
Okay, perfect. Thank you for that. Let's talk a little bit about some of the complications of endovascular aneurysm repair. Now, endovascular repair is where stent graft anchors from inside the arteries and holds on to the arteries to exclude the aneurysm. So most of the complications are secondary to either how the procedure is done or to the long-term outcomes of the stent graft's inability to hold on to that wall, the healthy wall. From the procedure, the biggest complications really are groin infections and local complications from the place that we enter the artery. And we can certainly deal with that, and majority of the complications we can deal with pretty readily. I think the complications that become very important to follow are the complications that might occur in long term. And what that means is over 6 months, 1 year, 2 years, 5 years, and longer, there might be certain things that might develop. If the stent graft moves from where it is initially left, that is called stent graft migration. And if that happens, that can cause the stent graft to lose its ability to exclude the aneurysm. And we might have to do something to add another piece of stent graft to make sure we can go back to forming a complete seal around the aneurysm or at the proximal or distal fixation site, wherever the stent graft is anchoring on. The other things that can happen are things such as endoleaks. Now, endoleaks are entities where blood flows from the normal part of the aorta into the aneurysm. And when that happens, that causes the aneurysm to be repressurized. This can happen from proximal or distal fixation site. Remember I said the aneurysm stent graft is like a pair of pants, waist and iliac limbs. So this can happen from the waist or from where the iliac attachment site is. If that were to happen, we need to go in and intervene and fix that. And that can usually be done by additional stent graft extensions or angioplasty and stenting. There's a different type of an endoleak which comes from collateral blood flow. Normally, blood comes down into the aneurysm and goes out from these tiny blood vessels which are called the lumbar arteries. Instances when the aneurysm is completely excluded, blood can flow back from the lumbar arteries into the aneurysm. If that were to happen, that's called a type 2 endoleak. And that's a type of endoleak that usually is benign, but sometimes it's not so benign. And depending on your situation, we might have to deal with that. Most often, we can take care of it by, once again, percutaneous, minimally invasive means without making incisions or without requiring general anesthesia. I'll stop there. One of the reasons we need to have long-term follow-up after endovascular aneurysm repair is because once we leave the stent graft in its place, and that excludes the aneurysm, over time, different parts of your body, different parts of your aorta or your iliac arteries can form an aneurysm. If that happens, if those arteries are weakened, then you can have stent graft that can slip down and once again cause the aneurysm to be pressurized. And once the aneurysm is pressurized, we need to find ways of dealing with that. Now, overall, the chance that you would require secondary procedures because your stent graft moves over long term is about 5% or less. The chance that you would require secondary procedures because of other complications that might develop over long term are overall about 10 to 15%. In most of the cases, we can take care of the complications by minimally invasive endovascular ways. The chance that no matter what we do, your aneurysm will not be able to be fixed by endovascular means and you will eventually require open surgery over the course of your life is probably 2% or so. Otherwise, in 95 to 98% of patients, once we go down the route of selecting the patients appropriately and doing endovascular repair, we can carry them through that for the rest of their lives. I'll stop there. Hello. Your doctor has diagnosed you to have carotid artery stenosis. What that really means is that you have some blockages in the arteries in your neck. Let's talk a little bit about that. The biggest risks of carotid artery stenosis is stroke. Now, unlike blockages in arteries when it affects the legs and other parts of your body, when they become severe, they can cause symptoms such as leg pain, etc. When you have carotid artery stenosis and blockage in the arteries in the neck, the first symptom could be a stroke. So we need to pay careful attention to diagnosing and identifying the degree of blockage there is so we can manage that and take care of you. So now that we've identified you to have blockages in the carotid arteries or carotid artery stenosis, let's talk about what some of the options are. There are fundamentally 3 options for taking care of patients with carotid artery stenoses. One is medical management, where we modify risk factors and we treat patients with antiplatelet therapies such as aspirin or Plavix. The other 2 options, if we get to a point of treating the blockages in your neck, especially when the carotid artery stenosis is severe, are called carotid endarterectomy, which is a surgical approach, and carotid artery stenting. And we'll talk a little bit about that. I'll stop there. Let's talk a little bit about medical management. Now, if your carotid artery blockage is less than 60 or 70%, and certainly if it is asymptomatic, so it's not causing you to have any symptoms of transient strokes or mini strokes that can best be identified by your neurologist or by other medical doctors, then we have some time to wait. And what we do in these instances of treating asymptomatic carotid artery stenosis is modify the risk factors, control the blood pressure, control the diabetes, control the hypertension, and then move on to treating you with antiplatelets such as aspirin and Plavix. With that said, we're going to need long-term follow-up with simple tests such as duplex ultrasound, which is a non-invasive test, to keep an eye out on the carotid stenosis to see if there's progression, or what I mean is that if the artery if the narrowing in the artery starts to get more and more severe. And if it were to get more severe and reach more than 60 or 70%, certainly more than 70%, then we have to start to talk about what are some of the treatment options that are available. Now, the two treatment options that are available today are carotid endarterectomy, which is a surgical approach, and carotid stenting, which is, once again, the minimally invasive approach. So let's talk about carotid endarterectomy. Carotid endarterectomy is where we make a small incision at the base of your neck. This can be done with a cervical block, which is essentially local anesthetic, and sometimes patients can go to sleep also, but most often we do it just with giving local numbing medicine. With that, we identify the artery, isolate the artery, clamp above and below the plaque, remove the plaque, and put the artery back together. The operation takes about 45 minutes to an hour, sometimes a little bit longer. Most patients stay in the hospital for 1 day and are discharged. Most people return to normal activities within a few days. Now, when it comes to going back to fully normal activities, such as lifting heavy weights, etc., we like to ask patients to wait at least 2 weeks or so before they can resume that. Let's talk a little bit about risks for carotid endarterectomy. Overall, there's a 1 to 2% chance of a stroke from the procedure. So the reason for doing the surgery is to prevent stroke. And the reason we do the surgery is if your risks of stroke are more than the risks of preventing it. So essentially what I'm saying is that if you have asymptomatic carotid artery stenosis, then your risk of stroke over the next 5 years, if we do nothing and only manage this medically, is about 11%, a little over 10%. And by doing carotid endarterectomy, we would decrease the risk of stroke to about 1 to 2%. Now, if you have symptoms from a blockage in your carotid arteries, then the risk of stroke are about 25% or greater within the next 2 years. That's a pretty high risk. And the reason, once again, for doing surgery is to reduce that risk from 25-26% to roughly 1 to 2%. I'll stop there. Carotid artery stenting is the minimally invasive way of fixing blocked arteries in the neck, or carotid artery stenosis. What is done during carotid artery stenting is that percutaneous access is obtained from remote sites. And what I mean by that is that we get access from the level of your groin into the femoral arteries by giving local anesthetic and without making any skin incisions. We access the artery, travel from inside the artery all the way up to your chest, take pictures to see where the carotid arteries are and where exactly the lesions are in the carotid artery or the blockages are. What is typically done after we get access is we pass a strainer, and it's really called a cerebral protection device or distal embolic protection device. And what it looks like is essentially a strainer. It's a small basket that sits above the blockage at the base of your brain, and then we deploy the stents and do the rest of the procedure to open the arteries below that. In that process, if there's any debris that breaks, it's captured by this filter or this strainer. After the procedure, what we do is we collapse the strainer and remove it from the artery. And this prevents any debris that breaks from the artery during the procedure from reaching your brain and certainly preventing stroke. The risks of stroke from carotid stenting are very comparable to the risk of stroke with carotid endarterectomy. You certainly have to find the experts who are the experts in doing these procedures. I'll stop there because I was going to go on a tangent. Now that you know that you have carotid artery stenosis and you understand all the risk benefits with various options that are available, I think it's probably best if you go home and think about all the options. We'll talk to your doctors, and at a later time we can regroup and we can figure out which is the best treatment option for you. Fine? Now I need to do that with the aneurysm, right? Same thing? Okay. Now that you know you have an aneurysm, we've certainly talked about all the risk benefits and all the treatment options available. I think it's probably best if you think about all the treatments available. We'll talk to your doctors, and we can meet again in a week or so to talk about and certainly decide on what is the best option for you. That's it.
Yeah.
Or simple. How are these coming along for you? Cut and pasting. We're going to be able to make something good out of it?